IgG4-related disease is one of the most fascinating and sneaky autoimmune conditions out there. It's a master of disguise, often mistaken for cancer, infections, or other autoimmune diseases. But once you recognize it, it's actually a treatable immune-mediated disease. So what exactly is it? Before we begin, this video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check information with trusted sources. IgG4-RD is a systemic fibroinflammatory disease. It causes inflammation and fibrosis that can form mass-like lesions in different organs. While IgG4 levels are elevated, the IgG4 antibody itself probably isn't the villain. It's more of a signpost for deeper immune system mischief. What's going on in the immune system? This disease is driven by immune dysregulation. T helper 2 cells and regulatory T cells release cytokines like IL-4, IL-10, and IL-13. That triggers B cells, especially plasmablasts, to produce large amounts of IgG4. Histologically, you'll see dense lymphoplasmacytic infiltrates, storiform fibrosis, and obliterative phlebitis, which is inflammation that can block veins. Who does it affect? Typically middle-aged to older men, but it can affect anyone. It's rare but likely underdiagnosed, especially early on, because the symptoms can be subtle or nonspecific. And it can show up anywhere. The pancreas, you get type 1 autoimmune pancreatitis. Salivary and lacrimal glands, that's Mikulicz disease, painless bilateral swelling. Retroperitoneum, retroperitoneal fibrosis, which can squeeze the ureters. In the kidneys, it causes tubulointerstitial nephritis. In the bile ducts, IgG4 sclerosing cholangitis. Thyroid involvement can show up as Riedel's thyroiditis or even overlap with Hashimoto's. Lymph nodes, painless lymphadenopathy. And it doesn't stop there. It can involve the lungs, orbits, meninges, and even the aorta. So how do we diagnose it? Diagnosis requires a combo of clinical findings, imaging, lab results, and especially histopathology. The big three features under the microscope are dense lymphoplasmacytic infiltrate, storiform fibrosis, and obliterative phlebitis. On immunostaining, you'll see over 10 to 50 IgG4 positive plasma cells per high-power field, with an IgG4 to total IgG ratio above 40%. Serum IgG4 levels can be elevated, over 135 milligrams per deciliter in about 60 to 70% of cases, but it's not definitive. Normal levels don't rule it out, and high levels don't confirm it. It's helpful, but not diagnostic on its own. The differential diagnosis can be tricky. You need to rule out conditions like lymphoma, pancreatic cancer, primary sclerosing cholangitis, Sjogren's syndrome, sarcoidosis, ANCA-associated vasculitis, and tuberculosis. Misdiagnosis can lead to unnecessary surgery or chemo, so a high index of suspicion is key. The good news, IG4-RD is treatable. First-line treatment is glucocorticoids, usually prednisone at 0.6 milligrams per kilogram per day. Most patients respond quickly, but relapses are common. That's why a slow taper over several months is important. If steroids aren't tolerated or there's a relapse, rituximab, an anti-B cell therapy, is very effective. Other options like azathioprine, methotrexate, or mycophenolate can be used as steroid-sparing agents, though the data is less robust. Long-term monitoring is crucial. That means regular checkups, imaging to watch for lesions or fibrosis, and sometimes tracking serum IgG4 or plasmablasts, even though those don't always match disease activity perfectly. If organs like the kidneys, pancreas, or aorta are involved, follow-up is even more important. To sum it up, IgG4-related disease is a multi-system fibroinflammatory condition that mimics malignancy and autoimmune diseases. Diagnosis relies on histopathology, supported by labs and imaging. And with the right treatment, especially steroids and rituximab, patients can do really well. Early recognition makes all the difference.